Thank you very much, Ms. Titi Ego. And I'd like to thank Ms. Ruth, Dr. Ruth, for the kind introductions of us. Thank you so much. So to continue where Ms. Titi left off, NANNA actually no longer provides funds for mission. NANNA used to provide funding for health mission, but we have moved even beyond that. We are now leaving the health mission to individuals, either chapters or individuals or a group of people. However, NANNA will still continue to support with logistics anytime anyone wants to take us to their village for health mission. We assist with administration, anything you need at all. We get a lot of calls. You can reach out to any of the leaders of the health mission, including our chairperson, Ms. Totin, myself as the national coordinator, and we have a lot of leaders who have been doing this longer, even that we have been doing, like Dr. Mbibi, Dr. Grace, Dr. Iwu, and a host of others in healthcare mission. We support with local volunteers. We do have a group of local volunteers in Nigeria, nurses that support us. We have doctors, we have pharmacists that we have been able to bring on board, that anytime we want to do health mission and you let us know about it, we will connect you with these local volunteers across board that will come alongside you to be able to succeed in your mission. Then, of course, approval from the Federal Ministry of Health. NANNA has collaboration with Federal Ministry of Health, and Dr. Grace will speak a little bit about that when she wants to talk. So we collaborate with them. So we actually get approval from Federal Ministry of Health every time we want to do mission. So what we try to do is to break this into quarters. So that's why we wanted to inform us in advance. So all the people doing their mission every quarter, we just apply together to the Federal Ministry of Health. And the same thing goes for NAFDAC. Because legally, you are not supposed to bring medications, especially prescription medication, into Nigeria without NAFDAC approval. So we've been able to have, to set up something with NAFDAC that if you go through health mission, we get a list of all the medication you need. And we also have pharmacy partners in the United States who supply all these medications to NANNA members at very, very reduced costs, like costs that are even almost cheaper than the one that they can get as bulk in hospitals. However, it needs to come through NANNA, and we need to get all your requests on time. So we send them to NAFDAC, and we get approval for NAFDAC. So when you are going home with all this medication, sometimes I go with 2-3 cases of medication to help people pack, take their medication to Nigeria in advance before they come, because I go to Nigeria often. And all we need is the NAFDAC approval on top of my suitcase. Passes through custom, passes through everywhere, just like that, because we have done due diligence. Another thing we help with is procurement of other equipment that you may need for your health mission. It's very important for us to do this because of the collaboration we have with the government. And these are some of the reasons they really trust us as an organization, because we actually go by the rules. Now, with the Federal Ministry of Health and NAFDAC, there are some requirements that we do need to have. That means the nurses going from America, they must have active license. They must be registered nurses with active licenses. And then we get a list of those names. Sometimes they don't check, but you just never know. There was a time we did an health mission in Ogun State, Odogbolu. Thank God that we had all this. We had NANNA nurses from the east, from, was it Abia or Anambra? We had some of NANNA nurses who were just coming home. They have not even gone to their own villages. The first place they came was my town. And then we got there. The Commissioner of Health in Ogun State was requesting for our licenses, for all the things we have, all the permission we had to do that mission. Thank God that every single time we tried to do the right thing. So we just presented everything. And they were really impressed with the preparation and what we do in NANNA, that we try to just go by the book. We do what is right. Then we need a letter we call it letter of intent. That means to do a letter of intent to the Federal Ministry of Health that will be conducting mission in let's say 3 states. We name the states and we name the towns in that letter of intent to the Federal Ministry of Health. And then they require us to list all the medications we are taking to Health Mission, including the expiry date. This is very important. They will not approve any medication that has, less than 6 months to expire. Then the list of U.S. nurses participating in the mission, the justice and our state. That one is also for our own record in NANNA. So we know how many states and nurses from each state participating in particular mission. Then upon completion of the mission, we generate a brief report to send to Federal Ministry of Health for their data collection. Then post-mission, we encourage our members to actually do an exit interview so that they can engage the local organizers, the local government, the state government, and we call them in Nigeria, they call them MDAs, ministries, departments, and agencies. I'm learning a lot of languages in Nigeria that are just peculiar to Nigeria operations in the last 1 year. So what are those things that we need to put in this report that we are going to generate? We don't want to bother mission providers. However, we are nurses. We know whatever we do, if we do not document, we have not done it, right? Excuse me. So what do we need in this? Number one, we need the location of the state and the local government and the town that this, or the village that this mission is taking place. Then, of course, we need the number of the people you have seen, the number of days the mission will take or has taken you, age, gender, and all those good information we collect as nurses, the demography, the major categories of diseases and illness that you actually cared for. Then the category of persons who actually participated in your mission, because you will find out that you need more than nurses at every mission. You need to engage the local doctors in the primary healthcare centers, pharmacists, or sometimes pharmacy techs. You need people who will even help you with throughput. You need people, local people, who will probably help you speak the language. I am from Ogun State, and there's the local language, even in Ogun State, they call Ijebu, that I'm a Lagos girl, that I don't even know how to speak that language very well, even though I understand. So even for me, that I grew up in Nigeria, we had to engage local people to help us translate to the people that we are caring for. That is very important. And then, of course, we need a plan of care. Just summary, after your mission, how many people did you refer? Why did you refer them? Which are the collaborating facilities that you refer them to? Is it to a comprehensive health center? Is it to general hospital? Is it to a teaching hospital? And why? And then what is your plan for follow-up for these people? Remember, these are people in the same community. So how do the nurses at the primary healthcare center that you are collaborating with, how do they follow up with these people? Thank God for technology now. Almost everybody in Nigeria, no matter how remote the village is, they have phone numbers. And this has really, really helped with taking care of our patients, where they work, live, and play, in population health, just like our keynote speaker said. Then, at the end of the mission, we say you write all those things. Then we really encourage us to actually document our challenges. Because what this does is that it helps other people going to be able to see what you have gone through and how you have been able to address these challenges and how you have been able to turn some of these challenges into opportunities. So I will just quickly talk about our timeline. Anyone going for health mission, the first quarter, we will expect the result, the report, to be submitted to NANNA the middle of the following month. Example, July to September. We will expect the report to hit, NANNA Health Mission by the 15th of October. If it's October to December, like this particular quarter we are, and we know a lot of people are planning health mission. Thank God in 2020, we couldn't do much. But in this 2021, we are out with a blast again. A lot of us are actually doing missions all over the place. So by January, we will expect reports to hit the health mission by the 15th of January. So then by the end of the year, we now collate all these things and send the report to the Ministry of Health. And of course, we have it too for our documentation and to see how we can improve on what we do. Some of the challenges we have is that when people go home to actually begin to work with their primary healthcare centers, as NANNA is encouraging, they find a lot of roadblocks. Working with Nigerian MDAs, ministries, departments, and agencies, it's so challenging. Number one, when you come from the United States, the first thing that comes to their head is you are coming to take their job. So for NANNA members, you need to be sensitive. You need to be professional. So what NANNA has done is that we identify that and we recognize that and we appreciate their concerns. So we now use the population health model. It's like engaging people at the grassroots. So number one, during your assessment, you want to go walk through your village or your town, get familiar with the leaders there and the decision makers, all those people who can make or break decision making in your environment. Talk to them, tell them what you want to do. Even for the people you don't know, they will direct you. And what we found out in all these 4 primary healthcare centers that we have adopted, every single one of us, same story, because that is the culture of Nigeria, is that when you go there and you respect their space, you respect what they have been doing, you do not come with this attitude, oh, we are the NANNA scientists, we are here to teach you what you don't know. That is the attitude that will not work in Nigeria. And that is one of the reasons a lot of our people, we are finding challenges. So when you go there humbly, you see what they do, you appreciate what they have on ground that is working. And then you let them know that this quality improvement that we are planning to do, it is collaborative. So you will be able to turn that particular challenge into an opportunity for the community you are helping and for you to make your project work easier for you. Another challenge that we find is finance. You see, adopting all these healthcare centers, primary healthcare centers, they are capital intensive. Because like Dr. Grace stated earlier, about 80% of these PHCs are not functional. The government has actually provided buildings for a lot of them. Some of them do not have buildings, like the one that they provided only land. And we did with the help of Dr. Mbibi. And the one, we did with the help of Dr. Iwutu in Imo State. But for like the one in Edo State, they have some structure, something. But a lot of work came into that. The one in Ogun State, they have the structure. They just don't have anything in it that is functional. So you will find these health centers in different stages. So you really, really have to think about what you want to do and the capacity you have. How are you able to pull people alongside yourself? You don't have to go it alone. You can go as a group or something, or you can reach out to all the other people who have money or who have clout in your community. Another challenge is working with government. That is like pulling teeth. We strongly want to encourage that you bring them on board right from the beginning, before you even set foot there. Call them, get the numbers of all the politicians, like the chairman of your local government. Then we have people we call Holga. They are like head of local government administration all over Nigeria. They call them Holga. Some of these people are medical doctors who head PhDs. Some of them are actually politicians. We are just finding out that all the Holgas are not medically trained. Some of them are political appointments. But you want to work with them because they are the ones that really, really control administration of all these primary healthcare centers. The moment you have those people on your side, it is smooth sailing if you have the money. Then you look for opportunities. So what NANNA does is that in this Take Me to Your Village, like I said, different states, different challenges. But the important thing here is that we are focusing more on prevention. Prevention. So that a lot of our people, they won't stay at home until they get in trouble and begin to transfer them to health centers, to acute care centers like general hospitals. A lot of these things can be taken care of in the primary health center, like prevention, the education, the treatment of minor. ailments, but they need somewhere to go. Like Dr. Grace said, and Ms. Titi, the reason we want to encourage having the mission at primary healthcare centers is that it will redirect the community to that particular place so that the nurses there can follow up with these people, and they can begin to care for our people where they live, work, and play. Now, adopting a primary healthcare center, we have a lot of them. The initiative focuses on 4 areas. Improve the environment of care. This is very, very important. We all know, and research has actually supported it. Number 1, if you improve the environment of care, patients are more likely to actually listen to you. They are more likely to be compliant with the education you provide. Now, imagine when you improve the environment of care, you are also improving the environment of work for the people working there. Again, extant research has shown that when you improve environment of work, output by the healthcare workers, they are actually improved. Another thing we do is capacity building of healthcare providers. In this Adopt a Primary Healthcare initiative, we train and collaborate and share best practices with the providers on ground. And we don't need to come from high post to do that. Basic things. Things like, I will use the Ogun State again for example. They've been doing AccuCheck and everything forever. But simple things like encouraging them about how they log in every patient, how they follow up, how they do all those things, all the little things that will just make their work easier, and it will be easier for them to follow up with their patient. And then a lot of things that we like train and retrain ourselves and these people too about healthcare, and especially about nursing. Like I said, data management and record keeping, very, very key. Then, of course, I mentioned this earlier. The 4th one is engaging our partners to build momentum. You see, when we are working, when you adopt a primary healthcare center, not everyone is going to be in Nigeria like me for 1 year. Until this particular project, I usually go to Nigeria for like 2 weeks, 3 weeks, 6 weeks max. So for a lot of our people who will be adopting primary healthcare centers, we don't get that much time in America to come and stay. You probably get a week, 2 weeks, 3 weeks off. So you need a lot of planning for you to be able to do this. And what you want to do is you want to engage the local partners. They will be giving you information besides the healthcare practitioners you are working with. When you engage the local communities, we have some people we call Oloritun in Ogun State, and I'm sure they have names in other states and dialect and other villages too. These are like the local chiefs and the local head of areas. They have your number, they are calling you, they are praying for you, they are telling you what is going on there. They will not allow anything bad to happen to that thing. We did not have to bribe a single person for everything we did in all these 4 states. Why is that? That is like almost not heard of in Nigeria. But why is that? Because of our engagement, primarily with the local people and then with the government. We did not have to, that is so strange. We do not have to bribe any local government person, any state government, nobody. And they came alongside us because of collaboration. And because, we did not go there as if we knew everything. Because let me tell you, in Nigeria, we have a lot of good things on ground in Nigeria when you really take your time to listen to them. So we would like to show you pictures of some of the primary healthcare centers that we have adopted. At the moment, 4. The first one is the one in Edo State, under the leadership of Dr. Grace in LPHC. This PHC was like, I wish we could show the before and after. And I think we did that during one of our sessions in NANNNA. But this is what it looked. It has even improved more than this now. Then the next one. The next one is the one for Ogun State. Actually, you could see the before on the right saying picture 1. That place was like overgrown with wheat, and they were practicing healthcare in that place. You will not believe it. Look at the far right. The number 2 and number 3 were like work in progress. Look at the far right. Of course, you know, in Nigeria, everybody's like friends with success. By the time we finish this health center, and may I say that in Ogun State, this particular health center, they call it, I've forgotten, they call it flagship. One of the best health centers by the time we finish. That was before. And you see the after. We just transformed that health center in addition to the training. We transformed it totally, including the bathroom, including the delivery room, the postpartum room, the outpatient, the everywhere, the nurses station. We transformed everything. When we finished, the local government chairman then, Mr. Olubile, now said he was going to invite the commissioner for health to come and commission it. So they had to commission it, and it was during COVID. So we did this, and it was really awesome too. We did it during COVID, and it was on Zoom. So this is for you to say, NANNA can do anything. And we were able to complete this even during COVID. And again, this speaks to collaboration with Nigerians. A lot of the people who actually assisted us to complete this Ogun State project, they were in Nigeria because we could not go home in 2020. And we were talking every day, we were communicating with the government agencies, with everybody. Then with our local nurses in Nigeria who could travel in and out of Ogun State. That was how we could do a lot of things, a lot of us in that COVID session. So can we go ahead and see the other one? Then the next one is, the next one is the one in Abia State. This one in Abia State by Dr. Imbibi. That was awesome. We did not want to leave Abia when we finished this project. They took so much care of us. You see, the thing about engaging the communities is that by the time you finish your project, the community members will have taken ownership of this project, because we're not going to be there forever. The goal is for us to set this thing up, and for the community members and the healthcare practitioners on ground to take ownership and begin to run with it. And then we just do our quarterly or half-yearly checkup to make sure that everything is still going as it should. And then, of course, we went to Imo State too, and we did the same thing under the leadership of Dr. Iwu, our president. Now, this was one of the pictures in Abia. We did not want to come back. Now, this is very important. Please, let's look at these numbers very, very carefully. Adopting a primary healthcare center is laudable. It is satisfying for us to commit and do this for our people. However, it is not cheap. For Abia State, if we look at NANNA contribution, NANNA gave each of these states $6,000. That was when dollar was like 300 naira, right? Look at what New York did. Again, $10,000, gave each state 2,500, because this was the first, group that we will do. But what I want you to really pay attention to is the community contribution. You remember I said for Abia State, it was only a land that was donated by some community members. So for Dr. Imbibi and their team, look at what they did. They were able to raise about $20,000. They did fundraising in the US, did in Nigeria, they did everywhere. $20,000. And some people even donated cement. I believe 1,000 cement. So this is engagement. This is where engagement also comes in, because you cannot do it alone. Well, I don't know, if I'm a millionaire, I'll come alongside you and help if you have a lot of money. But for a lot of us, we need other people to come alongside us. And then for every of the coordinators, look at it. Money came out of everyone's pocket. And then kudos to Minnesota chapter. They actually supported this project of Abia, and they contributed $6,000. If you look at the total expended for Abia, it's about $35,000. And then look at Edo State. The same thing for NANNA and everything. Again, money came out of the coordinators' purse. Again, look at Imo State. $2,000 from the coordinator. Look at Ogun State, about $4,000. Then we want to say thank you to New Jersey chapter, because like I said, all of us, we were completing this during the COVID. So they were not really seeing us on ground as they were seeing us during the 2018 and 2019. But we did not leave them alone. The important thing is to keep engaged with these people. And thank New Jersey, they gave us $1,000 each again, that we were able to actually send palliatives to all these groups during the COVID-19.
This question goes to Miss Esther. If the local people that are helping us, okay, when we go to initiate or when we're going to adopt this primary care, who is paying them? Who is paying
Oh,
them
that's a
if they are
great
being
question.
paid?
Thank you, Dr. Ruth, and for the nurse who asked that question. Very, very great question. Now, for a lot of the interpreters, it is voluntary. We have never had an interpreter that will request for payment. However, for a lot of the nurse volunteers and the doctors who come, we provide stipend for them. When we first started, it was really hard to get people to come and volunteer for free because of the economic condition in Nigeria. So it's like they will demand to get paid. And for the doctors, sometimes they will demand as much as 10,000 naira. And for the nurses, as much as like 7,000, 8,000, like how much they really get paid, because they're going to like per day. But you know, with the as we went on and they began to kick into what we are doing, they began to feel, to have this volunteer spirit too. And then all of a sudden, they would just say, don't worry, we will just come. And then we begin to even have extra people come. But I think it is prudent when you are planning this for you to make arrangements for stipend. Because, they have to like get on the bus or something to get to your village or get somewhere in addition to that. But for the translators, they are local people. So we have not heard of any translators getting paid.